Hi, we are here to do our ethical dilemma case study and presentation. I am Jenny, and we will also be hearing from Geraldine and Beth. So our ethical case is Mr. Green, who is a 57-year-old man with aggressive prostate cancer who is cared for by a nurse practitioner as part of his interdisciplinary care team. Mr. Green was diagnosed with prostate cancer 7 years ago, but refused medical and surgical treatment at that time. He chose to seek alternate alternatives and did not follow up with the urologist over that 7-year period. Mr. Green now presents with anemia and hypopatremia. After several diagnostic tests, it was discovered that the cancer had spread now to the lymph nodes, and the primary tumor is invading his bladder and partially obstructing his left kidney. Mr. Green has had several hospitalizations with extensive growth of that tumor. It was determined that further surgical and medical treatment would not be appropriate in his case, and a palliative care regimen was the next step. Mr. Green informed the nurse practitioner that he resigned himself to the fact that he was going to die. He also confided that the nurse practitioner that he planned to kill himself and that it was a secret that the nurse practitioner could not tell anyone.
So, in continuation, what is prostate? The prostate is part of the male reproductive system. It is located below the bladder and above the muscles of the pelvic floor. Its most important function is the production of a fluid that, together with sperm cells from the testicles and fluids from other glands, makes up the semen. The muscle also ensures that the semen is forcibly pressed into the urethra and then expelled outwards during ejaculation. Prostate CA is a cancer that forms in the tissues of the prostate and usually occurs in older men. Research has it that besides non-melanoma skin cancer, prostate cancer is the most common cancer in men in the United States. About 230,000 men get diagnosed every year. About 29,000 die each year from the disease. It has not been established how many of those 29,000 died of the disease and how many died because of the treatment. The diagnosis and treatment of prostate cancer usually includes PSA testing, biopsy, surgery, drug, radiation, all of which have their drawbacks and health risks. But because of these drawbacks and the health risks, some men wonder if alternative treatments might be beneficial. Some of the common questions that are asked by patients is whether remedies as herbs and natural dietary supplements might help to treat or slow the progression of prostate cancer. According to the Poisson regression model, it showed that within the first year of diagnosis, men with prostate cancer had a significantly higher risk of suicidal and accidental mortality. Also, amongst men who were recommended definitive treatment, but either did not receive it or refused it, men with prostate cancer had a 32% higher risk of suicidal death and 44% higher risk of accidental death than men with all other cancers. While substantial research has shown a relatively higher risk of suicidal death in patients with prostate cancer compared with the cancer-free population, to our knowledge, we present the first report directly comparing the risk of suicidal death in men with prostate cancer to those with other solid cancers. And so cancer already gives higher evidence of suicidal ideation, but with prostate cancer diagnosis, that's even a higher percentage of risk. Men that are diagnosed with prostate cancer are at increased risk of suicide and also of anxiety, depression, post-traumatic stress disorder, psychiatric hospitalization, and treatment. An increased risk of suicide and cardiovascular events shortly after the date of cancer diagnosis was also recently reported, according to Carlson, 2013. Another thing is the increased risk of suicidal deaths that is associated with white unmarried elderly and men with distant disease. Study has it that there is an increased risk for this group in the population. And also those of them that have been diagnosed for more than 15 years, that also plays an important role because it does increase the risk of suicide. So white unmarried elderly men is a risk factor, and the number of years they are diagnosed greater than 15 years is also a time risk factor. So approximately 60% of men with prostate cancer, they also experience mental health distress, with 10 to 40% having clinically significant depression. Longitudinal studies of prostate cancer patients suggest that erectile dysfunction after curative treatment may have a significant psychological effect leading to depression. And this is very important because often at times these men, they feel that like they are useless, that the fact that they had that going on just makes them a lesser man, and that leads to depression. Further studies proposed a new screening algorithm put out by Clemson et al. 2018. This new screening algorithm suggests for an evaluation with the expanded prostate cancer index composite clinical practice, patient health questionnaire 9, and an 8-question suicidal ideation questionnaire. These are used to assess for health-related quality of life, depression, and suicidal ideation. So the burden of screening for suicidal ideation lies within the entire healthcare team, as there is a proven correlation of suicidal diagnosis with prostate cancer. Screening algorithms should serve as a trigger for timely and appropriate psychiatric referral to optimize outcomes in these high-risk patients.
Some terms that we thought were important related to our case were autonomy and informed consent. So autonomy is expressing respect for patients' autonomy, means acknowledging that patients who have decision-making capability have the right to make their own decisions regarding their care, even when those decisions contradict what their clinicians recommend. And informed consent, it is required from the physician to respect patients' autonomy by giving them the information needed to understand the risk and benefits of a proposed intervention, as well as the reasonable alternatives, including no intervention if that's chosen, so that they may make independent decisions.
Next, we're going to discuss the ethical framework using James Rest's 4-component model. This model components consist of sensitivity, judgment, motivation, and action. This model was developed in 1994 by a psychologist named James Rest. Sensitivity discusses or recognizing the ethical dilemma, being aware of the situation, and considering how it will impact others. It also covers the ability to identify the feelings or reactions of others. Judgment is which course of action is best, and the process and evaluation of all possible choices. Motivation covers moral values that motivate the individual to do what is ethically correct. And action is taking the best course of action and implementing it, and also anticipating all possible outcomes. Next, we'll break down these 4 components and discuss how they relate to our ethical dilemma. Under ethical sensitivity and our ability to identify the feelings or reactions of others, Mr. Green confided in the nurse practitioner and disclosed information that he was going to kill himself. He requested that the NP not tell anyone of his plan. The NP must take a step back and look at the whole picture here. The NP has been placed in a position where the patient is confided, but recognizes that ethically, intervention must be done for the safety of the patient. Now that we know that he's actively expressing he wants to harm himself, we're taking a step back and looking, is this really the case? There are many components to the scenario that must be taken into consideration. Actively listening to the patient may glean important information that will guide the next step of the NP. Realize that this may be his way of opening the door for a conversation about his fears of what the end of his life is going to look like. With that, we're being aware and sensitive to his situation and realizing that our initial reaction to this request must be tamed for therapeutic communication to continue. The initial response will determine how much detail Mr. Green gives the NP. Does he have a plan? Did he express why he wants to proceed this route? What are his fears as his disease progresses? And is fear of suffering driving his decision? On the next component, we'll be talking about ethical judgment. Which course of action is best? And this is the process and evaluation of all possible choices. We want to respect the patient's autonomy, but realize that in doing so, we could be breaking legal, ethical, and policy guidelines. We must do the least harm to the patient while following established guidelines. We're going to process and evaluate all of the possible choices. The possible choices are: 1, to do nothing, which violates legal, ethics, and policy, or pull the team of professionals in to assist in the next steps and to get Mr. Green the support that he needs. Institutions often have ethics committees that are essential in dealing with these ethical dilemmas. The next component is ethical motivation. And this discusses the moral values that motivate the individual to do what is ethically correct. This is where we make a decision and take action. Ethically and morally, we know that the NP can't ignore this. The NP is not alone. The team of healthcare professionals can come up with a plan and approach the patient in a non-confrontational way to support him. The NP cannot do this alone. The team can assist on deciding what the best approach is and providing him with the support that is needed. The last component of this model is ethical action. This is where we're going to decide the best course of action as a team and move forward. In doing so, we must anticipate all possible outcomes. Deciding the best course of action and implementing this, and understand that this may drive the patient away from the group of healthcare providers. It also may result in extreme anger from the patient. It is important to anticipate this reaction and prepare for it. We want to convey the decision to the patient. Our approach is going to be key. The patient should not feel ganged up on. In doing so, we're being respectful and conveying why we made that decision and explain how the team came to the decision. This may help the patient understand why the decision was made.
In part of our ethical action, as part of our ethical framework, we pull together our stakeholders. And we have decided as an ethical team that our stakeholders are, of course, the patient, Mr. Green, the nurse practitioner who has heard the story from Mr. Green, including the family, the palliative care team, including the urologist, and also including the spiritual care team. And knowing that it's important that we recognize that the resolution of this ethical dilemma does not fall on just one person, but all stakeholders. And employing the healthcare team will allow different viewpoints so that the best case scenario can be approached. And we also want to make sure that we are meeting Mr. Green's needs, psychological, social, and spiritual.
So we're going to talk about some of the possible actions or probable outcomes for each of these alternatives. More or less focusing on the nurse practitioner. The nurse practitioner is the one that, for the most part, spends more time with this patient. And how the nurse practitioner reacts or responds to the patient goes a long way to determine whether it's going to be a good outcome or not. So looking at the moral sensitivity, the probable outcome for this is failure to recognize situations are morally relevant. So if the nurse practitioner who is on ground caring for this patient does not recognize that this situation is morally relevant, she will not be able to take it to the next level. So that's termed low moral sensitivity. So it is important as practitioners that we evaluate every situation and respond to it appropriately and adequately for a good outcome. We can't just brush it off and make believe that, is not relevant. Because if we do that, it stops there and there's not a good outcome. So it's very important that as practitioners, we are morally sensitive. The next component is the moral reasoning. This component involves 3 levels. It involves the pre-conventional level, which is the lowest level, the conventional level, that's the intermediate or second level, and the post-conventional level, that's the highest level. The probable outcome could be the nurse practitioner operating on the pre-conventional level, that's the lowest level. In this case, you have the practitioner focusing on herself and how this whole thing will impact her rather than the patient and the situation. And it is under this situation that you will see the nurse practitioner thinking, oh, I'm not going to get involved because I might get sued for divulging information. But it shouldn't be so, because moral reasoning mandates and that we as nurse practitioners release the information, even with the backing of HIPAA, which is the regulation that is put in place by the state to back us up for giving up information. So moral reasoning, we shouldn't, as nurse practitioners, operate on that pre-conventional level. We should strive to operate on the post-conventional level. Moral integrity, this is the third component, and is often called motivation or character or commitment. A probable outcome for this is the nurse practitioner feeling that Mr. Green's problem is not her concern, but other people's. And because of this, choose to do nothing. This is termed a low level of integrity. If every nurse practitioner chooses to say or feel that, it's not my problem. So, for example, Beth comes and says, it's not my problem. I come and I say, it's not my concern. And Jenny comes and says, not a concern, the patient suffers. So we have to have that high level of integrity. With that high level of integrity, we know to do what is morally right. And the last is the moral courage. A probable outcome is the nurse practitioner freezing up or making ambiguous gestures instead of effectively dealing with Mr. Green's issues.
So Geraldine brought up the term HIPAA, which is the patient confidentiality regulation. HIPAA does have some interesting key points that I was able to find with some research. There are exceptions that involve threats made by a patient to harm himself or another. So breaching that confidentiality, there are exceptions to the HIPAA rules and regulations. So HIPAA's implementing regulations allow disclosure of personal health information when disclosure is necessary to prevent or lessen a serious or imminent threat to the health or safety of a person or the actual public. And it is to a person or persons reasonable to prevent or lessen that threat, including a target or threat. So it gives nurse practitioners and it gives us as healthcare individuals the exception to make sure that threats made by patients to harm themselves or harm the public, we can disclose that information. Additionally, physicians should be also required to report these concerns for violence or suicide, and when they are permitted to do so. So in situations in which such reporting is permitted, they should balance patient autonomy with the patient and including also public safety. So with all of that being said, as a group with justifying one choice or a final decision by evaluating, so going through all of the research and going through our ethical framework, our final choice was we're going to do something. We're not going to walk away from the situation, act as though we didn't hear it. We are going to do something. One of the first potential actions that we are going to do is we are going to perform that suicide risk assessment. Find out, is he truly suicidal? Does he have a plan? We really need to assess that situation. We're going to reassess with the team. That's why it was important in our ethical framework that we included those stakeholders. We want to reassess as an entire team to come up with the best decision for our patient, Mr. Green. And then we're also going to provide education. Was Mr. Green concerned because he didn't have the knowledge? His fear and thinking that he was suicidal was because he didn't want to undergo chemo treatment because the neighbor told him how horrible it was. So by re-educating him, re-educating his family, we can help him make the best decision possible. So our choice as a group is we are going to do something by utilizing our ethical framework that we have chosen. And this is the references that we used to come up with that presentation. And we thank you very much.